We'll be discussing medical ethics in a end-of-life care perspective also. And today we have Dr. Sanghamitra Bora as our faculty. She's from Assam. She's leading the palliative care in the Assam Cancer Care Foundation. She also has a NGO on her own, which is called Arjuvan Healthcare Foundation. She's done her MSc in palliative medicine from Cardiff University. She's a trainer for national faculty for IAPC training programs, and she's also a faculty with Pallium India for many years now. So she'll be talking about end-of-life care, touching upon the medical ethics part also. So I understand medical ethics is very much a part of 8Com modules, and you all will be actively involved in teaching medical ethics. So we expect you to contribute to whatever we are talking today.
Dr. Sanghamitra, it's over to you.
Hi, good evening. Really sorry for this delay. There is a power failure at my end, and I had to borrow my son's laptop because my laptop has been drained out of its battery. So, not going into much of my talking, I'll just start to share my screen, and we'll start with the PPT. Give me just 1 second. Yeah, can you see my screen?
Yes, ma'am. Not in slideshow mode.
Okay, so I'll make it slideshow. Yeah, is this okay?
Yes, perfect and good to go.
Okay. Okay, so today we'll talk about medical ethics and end of life care. And since we have clubbed both these topics together, you can understand the importance of medical ethics basically applying to end of life care when we talk about palliative care here. So I'll touch upon the definition, the 4 cardinal principles, and euthanasia, a little bit about euthanasia in medical ethics. And after that, we'll also, discuss about the end of life care. So basically, ethics by definition is a moral code of behavior. And the ethical principles are a set of principles which is also in a moral account and should be functioning as an analytical framework that expresses the general values underlying common morality. So the definition itself is actually, quite self-explanatory when you talk about working under an analytical framework and expressing your values when you are conducting yourself professionally or even outside of your workplace. You need to follow certain ethical principles, certain work principles which will govern your behavior and your kind of ultimate decisions that you will take while providing your service. And for palliative care, ethical principles are exactly the same as those of medicine in general. We need to understand that we as doctors, we have a dual responsibility, firstly to preserve life, and secondly to relieve suffering. And at the end of life, the relief of suffering is more important because the preservation of life becomes increasingly impossible. It is important that we, focus towards preserving life. We just cannot let a person die. But having said this, at one point of time, we have to understand that, perhaps our treatment, may not be working for this particular patient who is in an incurable stage. And at that point of time, it is our onus that we accept the ultimate reality that the patient is actually going away from us, from the family. We'll need to, counsel the family, or we need to facilitate this particular acceptance for the patient's family also, and then focus properly or solely on relieving the suffering of patients which are in an incurable stage. The 4 cardinal principles as applied in palliative care practice, it's definitely similarly to that of medicine, and these are the patient autonomy, the principle of beneficence, the principle of non-maleficence, and justice. So when we talk about patient autonomy, the questions that are pertinent at this point of time is, what does the patient want? And most importantly, does the family of the patient or the caregivers of the patient understand the patient's preferences at that point of time? Secondly, the question of will it benefit the patient, defines the principle of beneficence, and will it harm the patient? So whatever decision you take, whatever treatment you apply for the patient, these is that particular decision of yours or even the families going to harm the patient or not? Okay, so we do not want that to happen, and henceforth we need to perhaps rethink on our decision, or stop that particular treatment, or not take that particular decision for the patient. And then justice, of course, India is a resource poor country. We still have many more people who are devoid of the basic health services also. So we have to justify how we are going to apply our resources, how we are going to allocate our resources for such patients. So why at all are we today talking about medical ethics? It's because of the dilemmas that we face. There is a point in every professional's life where people get confused, or are not able to take decisions on which decision to take, or which path to follow. So that particular situation is known as an ethical dilemma, and basically it is a conflict of moral principles. It occurring when when a person faces certain situations where adhering to one particular principle might result in the violation of the other. So basically, ethical principles, need to be followed at the most in every situation. But when we are faced with dilemmas, it is on our skills, it is on our best judgment what to follow. And having said this, we will need to justify why we have actually followed one particular principle surpassing the other. So I'll just try to, give you certain examples, and you're ready to give your opinions on that, maybe in the chat box, or later on when we complete with the session, we can actually talk about that. So this particular patient, as you can see, is a patient with a jaw tumor, which is perhaps a squamous cell carcinoma or something. With this has resulted in a orocutaneous fistula. He's an elderly patient. He's a severe pain. But fortunately for him, there is no distant metastasis. So the surgeon or the treating oncologist decides on, giving this patient a Ryle's tube or an NG tube so that further treatment can be properly done. Now, the patient refuses to take the NG tube insertion. So at this point of time, as palliative physicians, if you are already working in an oncology setup, or you have come across certain situations in your practice or in your medical colleges, as I understand you are all faculties of medical colleges, those who are already working in the Department of Surgery, pathology, you will be you might have come across such patients, and if you do not have a counselor or you do not have a palliative care department, how would you handle this situation? So we will have to understand what is the dilemma here. Now, we want to do good by putting the patient on a Ryle's tube, and that is beneficence. We want to give this patient the benefit of putting a Ryle's tube and henceforth continuing with his treatment, which is actually going to give him a good life, cure him perhaps of the disease. But then it is the question of the patient's choice also, patient's autonomy. So now we are in an ethical dilemma. We are in a situation where we cannot overlook the patient's choice. I remember when I was in my MBBS course, professors and registrars, they never used to give any kind of heed to the patient's choice. They would just slap the whole treatment on the patient. They will not ask also what you want, what you don't want. They'll just tell them that we need to put you on a Ryle's tube, and if the patient comes, he comes. If he doesn't, then he's just gone. So but then times have changed, and we are all we are professionals who are ethically bound to practice medicine on a scientific background, along with proper ethical principles. So here the dilemma is between beneficence and autonomy. So when we talk about patient's choice or autonomy, let us just understand what it actually involves. Okay, so basically the patient has the right to have dignity, the right to privacy and confidentiality. Secondly, the patient has the right to have the information, or more precisely, the correct kind of information. Okay, and then thirdly, he has a complete right to make his own decisions. Okay, whether it is good for him, bad for him, whatever it is to make the right to make the decisions. And last but not the least, the treatment decision must come as an informed choice of the patient. Okay, we just cannot say ki you need a Ryle's tube, I'm going to put on a Ryle's tube. If you don't get it, then you're done. Okay, that is not the right way. We have to respect the importance of the decision coming directly from the patient's side. Okay, it will have two impacts. In fact, two good things, advantageous things. That is, one is the patient will happily come to you and be compliant to your treatment, and you actually go one step ahead in your goal of providing this particular treatment to the patient. So this whole thing, these four things actually make up patient's autonomy. So The basic underlying point being that the patient is involved in decision making. So for this particular patient, the autonomy is taking an informed refusal. And when we talk about informed refusal, we need to check the understanding of the patient. Does the patient understand the treatment at all? Have you checked with what he understands about Ryle's tube? How is it going to be inserted? Where is it going to go? How is it going to help him? Okay. Many a time you might as well, when you talk to the patient, when you try to check his understanding, you might as well find out that the patient thinks that it's going to go to my brain through my nose, So we'll have to correct that particular myth or that particular misunderstanding of this patient, right? Then explore the reasons. You explore why he is refusing, okay? You have checked the understanding. Okay, the patient knows that it's a food pipe, it goes to the stomach, right? But when you again, explore the reasons for his refusal, you might as well find out that the patient says, I don't have money to come. Who's going to cook food for me? I'm a sole, a person living all alone. Who's going to make liquid foods for me? Who's going to put all the liquid into the mixer grinder and then grind it and put it through? I can't do that myself, So those are the reasons that you will explore, okay? And then after you find out his understanding, you know about the reasons of his refusal, you then try to counsel. And when we talk about counseling a patient at this point of time, it is not just trying to, hammer the patient that whatever happens, you must take the Ryle's tube. No, it's not like that. You will need to, properly work out a solution for the reasons of his refusal. If he says that, I don't have anybody to, feed me through the Ryle's tube, I can't do it myself. You might as well have to find out a proper place for him to stay inside the hospital, within his financial limits. You might as well have to find out somebody, perhaps a neighbor or, a friend or a caregiver, or, go through an NGO and find out a, professional caregiver who might, for some, very less amount of money, might actually stay with the patient and do the job. So that is properly counseling the patient, facilitating his solutions to the problems. And then after all these three things, you still find out, you still have come to know that the patient still refuses, okay? You have to support the patient at that point of time also, okay? You have to keep your doors open for this patient because you want to do good, because you know that after taking a Ryle's tube, the patient is actually going to be benefited. So now the patient is refusing. Perhaps it is at the heat of the moment that he's still trying to refuse. No, I won't do that. I won't do that. But, having said this, in my career and in many physicians' career, patients have actually come back to us, and actually told us, because they found out that this doctor, even if I have refused, is with me, she has not screamed at me. She has not driven me away because I didn't listen to her. But she was calm. She tried to understand why I am doing this. But I think the doctor is right, so I'll go back to her, So this has happened a number of times in my career, you believe it or not. And I'm sure that, most of you who have actually taken such decisions in your life along with the patient, which you probably might have had, patients have actually come back to us. So this is autonomy for this particular patient. Now, this is another example of another child. He's a 20-year-old boy with an osteosarcoma. You can see the tumor just above the knee joint. It's a huge tumor, and at the lower end of the femur, he has he has multiple lung metastases also, and he's suffering from severe anemia. So now the patient says that I want an amputation. Okay, but as a medical team, you know that the procedure is extremely risky, and considering his general condition, you try explaining the risks to him. Okay, you've explained everything to him. You have told him that he might as well die on the OT table. He might not come back from the OT to his home or to the ward, but still then he is quite adamant that he wants an amputation. Okay, so how do we handle such cases? What happens? So there is a dilemma between doing good, because you want to do good by avoiding harm. Okay, and then the patient's choice. The patient's choice is that I will do an amputation. I want to go for an amputation. Whatever happens, I'm going to take the risk. Okay. So now, how do we actually approach this patient? So, questions that you will need to discuss with the patient. Okay. You will have to ask yourself and the medical team, your extended medical team, and the patient that what are the chances of cure? Even if the patient goes for an amputation, the surgeon decides that, okay, we'll do an amputation. Let's see. All right. We can just keep our fingers crossed. And, even if there is a 10% chance, let us do the amputation. Ask yourself, ask the surgeon, ask the medical team, what are the chances of cure? Okay. Here, the patient is already having lung metastasis. His lungs are actually going to give way very soon. All right. Even if you do an amputation, even if he survives an amputation, are his lungs going to support him for much longer time? What are you going to do next if that happens? Okay. So, secondly, what are the is the survival of this patient likely after the amputation? Okay. Similarly, will the amputation improve his condition, or is it going to make him more crippled? Okay. So these are the questions that you need to ask yourself. You need to discuss with the surgeon, and then sit with the patient properly, give him everything on a platter, and actually kind of make him look at the mirror and find out for himself the real situation that is going on with him. All right. This might sound very, very whimsical, or this might sound very, very illogical. But then the point here that you should remember is that counseling a patient does not mean that you will hammer your decisions on the patient. Counseling means that you stand by the patient, find out the problems in discussion with the patient, and also the solutions to this. The advantage that you have here is that you know about these solutions and the patient doesn't know. So another dilemma that we face quite often is that, the relatives of the patient, suppose this particular example, a 20-year-old boy with advanced cancer, the relatives have insisted that the issues of diagnosis and prognosis should not be discussed with the patient at all. All right. So when you go to see him one day, he's alone, and he asks you, what is wrong with him? So, will you not tell him about what is going on with him? Okay. So is it right to deliberately mislead a person? Okay. Or to withhold information that a person is asking for at the insistence of the patient's relatives. All right. So, the kind of approach we take for such situations is that uh, uh, perhaps at that point of time when you are, all of a sudden the patient asks you what is happening to me, you might as well try to avert the questioning and answering process by saying that as of now, I am also thinking about talking to you about this particular issue, and it's good that you have asked. Is it okay that we discuss this with your relatives when they come? And you might get an answer of kind of yes, let us discuss when my relatives come. You might also get an answer that no, you have to tell me now, because if my parents come or my relatives come, they're not going to talk, let you talk to me. And if that happens, then you know where the problem is, and then tell the patient that it's okay. It's very important that we involve them also in what is going on with you. We discuss with them also, and perhaps that is going to ease your way out to make them understand that you are comfortable with the kind of problems that you're having, and we together sit together and find a way out of this whole situation. So much of your communication skills come into play when you are revealing somebody's diagnosis and prognosis. Okay. And on the other way around, if you also try to talk it out with the patient's relatives, you might as well find out that the only thing that they want is their patient should not be hurt by any kind of bad news. Okay. So, and they might not as well appreciate the fact that the patient already knows, because see, 20-year-old boy is already an adult. Okay. He has all the rights to know about his diagnosis. He has all the rights to know about his prognosis. And having said this, for a parent, a child will always be a child of any age, a son, daughter, whoever it is, will always be a child. And they will always try to protect that particular child from any kind of harm. All right. And this particular situation is a very nasty situation where, the parents are helpless. They want to help the child. They know also that what is going to happen, and still they cannot face this particular situation. So your communication skills are, are a kind of facilitator in, removing the darkness that is between the patient and his or her relatives. So the most important thing, the most important principle that we might as well think about is the principle of justice. And as I said earlier, we need to balance the needs of the individual with that of the society. If we take an example of this particular patient, is already 86-year-old. He has lived his life, but his cancer is has been spread to the lungs, spine, ribs, the sacrum. He's already overloaded with a psychiatric son. He has 6 grandchildren to look after. At this point of time, the goals of care for a palliative care physician would be to take care of the pain, to take care of the, to address the finances of the family. Maybe, the three grandsons who might be needing some kind of a ritual like a Janevu Sanskar, etc. And then, realizing the fact that his breathlessness due to the lung cancer is increasing. And that is a clear indication that the patient is actually going away. So are we thinking about an ICU admission for this particular patient? Can we just give way to one of our most precious ICU beds for this particular patient? Cannot we think of, a young person who might land up in the emergency ward with a head injury and, might be needing the last ICU bed that was there? Can we just think about this particular young patient who can be put in the ICU, and then recovered from the head injury that he has come across? So, already overloaded, the whole society of India being such a populous country, and will this be a fair utilization of the family's resources, a fair allocation of the hospital's resources, of the society or the nation's resources? So it's a very hard decision for people like us. We are not staying in a very developed country where the doctor to patient ratio, the the bed to patient ratio, the hospital resources, and the abundance of so many things, so many resources all together are so very important. And that brings us to this very hot topic of euthanasia. So are we actually going to euthanize these kind of patients who are 86-year-old? They're going to die already, and they are suffering in pain or, such kind of things. Are we going to euthanize? Because that is what is rampantly involved in now, today's society. I mean, people, when I go for home visits, for terminal patients, the family, I've faced with such questions like, when are you going to give him the last infection, the last injection, So these are very absurd kind of situations that people will face, and although we have been facing this situation since a long time, but whenever we are, we are asked this question, like that of a final injection or a final resort, that really jitters us a lot. So, sorry. So euthanasia is actually an act or procedure in which someone takes active means, such as a lethal injection, to bring about someone's death. And interestingly, when we allow the natural process of death to happen, it is not at all counted as euthanasia. So, when we allow natural death to occur, that would be definitely by withholding or withdrawing a futile kind of a treatment. Okay. We'll explain in our further slides what is futile treatment. And euthanasia, as you know, it is not allowed in India. It is not legal in India, although many other countries like Netherlands, Belgium, etc., they are they do practice euthanasia. So excuse me. So it is definitely a deliberate intervention which is undertaken with the expressed intention of ending life to relieve the intractable suffering. So, one of my mentors, he actually, in his talk on euthanasia, actually told us that euthanasia is nothing but a deliberate murder. You are actually killing a person, whether it is by the person's wish, in conjunction or in consensus with the family. You are deliberately injecting something, taking an active means to end the life of the person. Okay, you're not allowing the natural death to occur to this particular person. Okay, so it is amounting to murder. It cannot be counted as, mercy killing and all these fancy words that are used for euthanasia. They do not really, make a different spot for such type of acts. It has to be a deliberate intervention. And when we allow natural death to occur, we are not killing the person. Okay, this particular, we are actually withholding, we are actually holding the patient not to go through that natural process. We are if we go and ventilate the patient at that point of time, we are unnecessarily prolonging his deaths. Okay, so euthanasia is always an active euthanasia. It cannot be passive euthanasia. There is nothing called passive euthanasia. It is always an active means, and henceforth it is an active euthanasia. So when we use oral morphine, when we use other drugs to relieve pain, we are not practicing euthanasia. When we are stopping treatment, when the burden of treatment outweighs the benefits, then also we are not doing any euthanasia. And we are allowing nature to take its course, and henceforth that also doesn't amount to euthanasia. So that brings us to the most important topic that we face in palliative care. Almost 70 to 80% of our patients, when we get them, are at the end of life, unfortunately or fortunately, and that is the reason why medical ethics are so much intertwined with that of end of life care. So I'm going to talk about the outcome of end of life care, which is a good death. We want to give this patient who is at the end of life a good death. We need to facilitate a good death so that the relatives are not haunted in the future by the screams, by the kind of suffering that this patient had to endure. We are also going to talk little bit about futile care. What is futile care? How we can avert futile care, and how to limit life-sustaining treatments. And then how do we recognize the dying process at all? Is there a scientific basis to do that? So this would be about end of life care. And talking about
sorry to interrupt, Sanghamitra. There is a comment in the chat regarding the ethics. So can we so Dr. Suraj is telling that I differ in the interpretation of justice in medical ethics. It's about utilizing available resources well for one individual rather than deferring responsibility of resource allocation to the physician. Would you like to comment on that?
Yeah, Dr. Suraj, I also, would like to, not differ, but to say that it is the other way around that you have presented it. I think, when we are allocating resources to our patients in a justified manner, we are anyway utilizing the resources well. Don't you think so?
That is usually that is the interpretation in medical ethics actually. But with the palliative care approach, I think that this should be different. With the resources allocation is not physician's responsibility. That is my first thing. I think that whether we are giving justice to the patient with the available resources, that is primary responsibility of physician.
That is,
Not
yeah,
that,
yeah. I understand what you are coming to. I agree with you. But having said this also, what I would like to point out here is that when we are allocating some resources to our end of life care patients or a palliative care. See, now you are confusing with palliative care patients also, because perhaps you're thinking palliative care patients to be only the incurable ones. It cannot be like that. Our palliative care generally would start from the point of diagnosis. Okay. And
that
many
is
of our patients are
the
also
example
not.
the example you took, the 80-year-old patient, and most of the people are immediately, to the conclusion, people come to the conclusion that this patient doesn't need ICU admission. So we are not in a position to decide for other person's life. We don't make the decision for them.
No.
If you
No.
take
I
this
think you
literal
are.
definition of medicality,
No, you are a little you're not confused. I cannot say confused, but I think
I'm not confused. I guess you
yeah.
took the example that I didn't,
Yeah, definitely. But don't you think that if we decide on not putting this particular patient in the ICU, we are justifying why we are not putting this patient in the
No, because
ICU?
just now you said that all the palliative care patients are not incurable, and I have seen
Uh,
patients who come in for end
no.
of life, get
When I
something
am
overnight,
talking
and then go
about
back home.
I am talking about this particular patient, the example of 86-year-old person. Do you, if when I am justifying the resources allocated for this patient, don't you think that we are practicing the principle of justice here?
Oh, I think that the basic, basic requirement for palliative care was that where palliative care started only because people were being overlooked, like old people, the infirm, nobody who is going to take care of those people. So palliative care started for that reason only, that nobody was going to look after them. So I think that is compromising the principle of justice.
I really didn't get how that is compromised, because what we are doing here is that the patient's family wants to take this patient to the hospital, and they want an ICU admission for this patient. Okay. At that particular point of time, when you justify that we have just one ICU bed, and for this particular reason we are not admitting your patient into the ICU, then I think that is where you are justifying the real allocation of your resources for other patients. That was, I think I was not able to convey the importance of the principle of justice, but this is what I had meant.
Okay, so that is what I want to differ about. We cannot choose one patient over the other. The way you are saying it is, we are justified in choosing one patient over the other. My point is, we
I
are not
think it is the
justified in
both
choosing
way,
over the other.
Dr. Suraj. I think it is the both way round. You have to do that also, because you are working in a multidisciplinary team, and not just because you have to take that particular decision along with your team, along with a team which is also working for other patients. Perhaps a ICU physician, perhaps an anesthetist, perhaps a surgeon. You have to take that decision in a team approach also.
We are making decisions for the patient all the time. So it again goes against the ethics, that we are not considering the patient. Again, we are, as a medical fraternity, we are making decisions for others. So that again goes against the medical ethics, principles of medical ethics. I
Okay, I
think,
think, all right,
yeah,
we'll
I
discuss
may not
this.
be convinced. I think we are taking a lot of time. I'm sorry.
No,
I'm
that's okay. We can continue with this discussion later on. I can
yeah,
share
sure.
my email ID
Yes.
with you, and then we can talk
Yeah.
about this.
Okay. Thank you.
Yeah, okay. So we were talking about the the concept of a good death. Why at all we need a outcome of a end of life care as a good death. So as you can see, there are a number of reasons, why what kind of a death should be there. So it's important to know that when death is coming and to understand what can be expected out of it. Okay, to be able to retain control of what is happening, to be afforded dignity and privacy, control over pain relief and other symptoms, the choice and control over where death is occurring, to also have an access to information and expertise of whatever kind is necessary, the wishes of the patient to be respected, and have an access to any special kind of needs that the patient has, to have a control over who is present and who shares the end. That is extremely important. To be able to leave when it is time to go and not to have life prolonged pointlessly. And one more important thing that I have missed here is that the place of death, where the patient wants to die. There are many patients who would say that, no, I want to, die in the hospital. I would like to stay in the hospital forever. So that is also a choice of the patient that is also needs to be respected. So these are the various components of a good death, and again, pain and symptom management, the clear decision making, preparing for death, the concept of completion. And when we say completion, it is meaningfulness at the end of life and dealing with faith issues. Many people are there who who would actually want will have a kind of a problem with their own gods. They'll have questions like, why me? Why has God done this to me? So these are a little bit of a faith issues. Many people would be there who would say, I don't believe in God at all. But still, I have a connect with superior source, and that makes me spiritual. So these are also some faith issues. The reviewing of life, resolving conflicts with the near and dear ones or friends or family. Then they would be contributing to others, like making provisions for a terminally ill patient to contribute for the well-being of the others. For example, I'll tell you my example. My father is a metastatic prostate, and he knows that he would eventually succumb to this particular disease, and he has already made plans to donate things. He has already told us where to do what. And, he wants to donate his body to the medical college and so many other things, So we need to facilitate that also when we think about a good death for a patient. And then affirmation of the whole person, as it involves the patient as a unique and whole person, and not understanding the patient from only the disease perspective. Okay, so these are the components of a good death. When we talk about end of life care policy, I would request all of you to please go through this particular joint statement. And it is by the Indian Society of Critical Care Medicine and IAPC. And they have actually brought out a 12-step pathway of how, end of life care should be delivered, where it starts and, where it actually stops. So the first step being the physician's assessment of futility. When the when the patient comes and, you get a patient at the end of life, it is the responsibility of the physician, of the medical team, to properly assess and find out the futility of the treatments that are going on. There will be many unnecessary treatments going on. There will be many, kind of polypharmacy going on for a patient at that particular point. I do not mean that they are all useless or, they have been just given like that. What I mean to say here is that, many a time, many people come together with a proper good intention of delivering the best of things to this particular patient. And unfortunately, the patient, unknowingly, lands up in polypharmacy. So when we understand this particular underlying point, we will have to find out the what are the futilities that are involved in the patient's treatment. Secondly, you have a consensus of providers. So when we say consensus of providers, it means that the whole medical team, starting from the nurse, to the pharmacist who is dispensing medicines, to the receptionist of the hospital also, or the ward manager or the floor manager, and so many other people who is involved in providing some kind of care to this particular patient who is at the end of life. There has to be a consensus. Okay, the medical team decides on the futility of the treatment. The medical team will deliberate upon what next to be done, and then they would pass on this particular message to all the extended people that are involved. Since we are always working in a multi-speciality kind of a team, we will also need to deliberate with them the treatment protocol that will be followed hereafter. And then we disclose the prognosis to the patient's relatives. Or if the patient is conscious and can understand or comprehend our steps or our decisions, then we'll have to disclose this particular prognosis to the patient, okay, and the medical team. And that is generally done by the doctor of the particular team. Going on to the fourth step, this is the communication of end-of-life care. So when we talk about communicating the initiation of end-of-life care, we mean that what are the treatments that need to be stopped from here, and what new steps are going to be involved. Okay, so that is how we communicate end-of-life care. And then there'd be a shared decision making. And when we talk about shared decision making, it is always taking the patient's relatives into a meeting, communicating with them, talking to them about what is the what are the steps we are going to follow. And then if at one point of time they think that no, we are we need a second opinion, or we want to take our patient to another hospital, please do stop at that point of time and allow them to do their own thing. But then, having said this, you will need to tell them the right kind of prognosis. You will need to share with them why you have taken this decision. Always document your findings. Always document the communication that you've already had throughout from step one. Okay, and then you will see that at one point of time they do feel that they have accepted the reality, and then you go to the seventh step, and that is you have a consistency of decision with the caregiver, and then if there are some kind of life-sustaining treatment being initiated, you will figure out what are the steps that can be limited from here on. We'll discuss this in a separate slide in our next slides, and then proper provision of end of life care, and not not really thinking about death, but then at the 10th step or after the death, you will also try to provide an after death care. After death care, bereavement support, and then reviewing the whole care process that you have had for this particular kind of an audit that you will need to do for all of these patients. So when we talk about futile care, as we have mentioned before, the AMA Code of Medical Ethics have actually, laid down that physicians are not ethically obliged to deliver care that in their best professional judgment will not have a reasonable chance of benefiting their patients. So henceforth, we have to understand the fact that the kind of futile care is being done, unknowingly by physicians, because of the fact that they are always obliged to do something for the patient, and that something actually drives them to more towards giving a futile kind of a care. And that is the reason why assessment of futility in the first step of providing end-of-life care is extremely, extremely important. Unless and until we understand the assessment of futile care being done, or any kind of extended care, extended treatment that is happening for any kind of patient, you will never be able to delineate or demarcate the initiation of end-of-life care. And, for end-stage pulmonary, cardiac, renal, or hepatic disease, medically futile, these are the medically futile conditions where end-of-life care is extremely appropriate. There would be severe sepsis, refractory illnesses with organ dysfunctions, which are unresponsive to a treatment, and non-reversible consequences of coma. Chronic severe neurological conditions with advanced cognitive and functional impairment with little or no prospects for improvement. And then progressive metastatic cancer, where all treatment options have also failed. Post-cardiorespiratory arrest with prolonged poor neurological status, and any other comparable clinical situations, coupled with a physician prediction of low probability of survival. So these are the conditions where we will need to assess futility and initiate end-of-life care processes. Let us take this example of Mr. AB. He's a 74-year-old gentleman with advanced carcinoma of the lung. He had completed a course of radiotherapy and 2 courses of chemotherapy. He's brought to the casualty. He's drowsy. His pulse is feeble. The systolic BP is 60 millimeter of mercury, and the breathing pattern is also altered. Now, the family wanted everything possible done for this patient. So what do we do in such a situation? Okay. Do we resuscitate and shift him to the ICU? Do we keep on investigating him? Do we also take care of the hemodynamic and ventilatory supports? what about the hydration and nutrition support for this patient? So now, this particular patient, if we assess this patient, we will, by virtue of prognostication, we will know that this patient is perhaps at the end of life. Okay, we'll definitely need to have our parameters ready and our documentation ready. But having said this, if we as a team have a consensus that this patient is at the end of life and we need to put him on an appropriate treatment, the key points would be the patient's biological prospects, the therapeutic aim and benefits of each treatment that we devise, the adverse effects of each treatment, and the need of not prescribing a lingering death. Okay, so appropriate treatment by definition means that this treatment does not provide net benefit to the patient, may ethically and legally be withdrawn, and the goal of medicine should be shifting to palliation of symptoms. So for patients whom we have very nicely, properly evaluated as being at the end of life, we will have to devise an appropriate kind of a treatment for such patients. So why do we assess or recognize medical futility at all? It is because that, recognizing medical futility and the dying process will be the first step in providing end-of-life care. Secondly, a reasonable prediction of mortality is essential to identify the patients in whom end-of-life care discussions can begin. Unless and until you start, a prediction of mortality, you will not be able to start with the discussion itself. And if you cannot start discussing, you will not be able to initiate end-of-life care. There should be, these should be based on the physician's objective and the subjective assessment of medical futility and the dying process. Now, there are alternatives or modalities of end-of-life care. And instead of an acute medical management, the options that would be available are when the family actually chooses for a comfort care only option. Okay, and that is the point where the physician should explicitly communicate the standard modalities of life limiting or life prolonging interventions. And those would include withholding of life support or non-escalating the life support that the patient is already in, withdrawal of life support, which is extremely important, and the symptom management and comfort measures that are to be tailor-made for such patients who are at the end of life. Life-limiting or sustaining treatment, how to discuss various modalities of limitation of life-sustaining treatment. Firstly, the common modalities involved not initiating new therapies aimed at care, withholding or weaning or withdrawing from mechanical ventilation, vasopressors, renal replacement therapy, therapeutic medications, nutrition, extubation. So all these things, should not be, should be kept at bay. And if the patient is already on those, then you will need to find a way out to wean the patient off all this therapy. And before proceeding with EOLC measures, it is necessary to prepare the staff. It is necessary to communicate this to the family. And if the patient is capable, please do communicate to the patient also. And the environment of the patient. You have to look at where the patient is being placed. Is the patient is in an ICU? Is the patient is in a ward? Does the patient want to go home? And how can you, elevate the environment of this patient to a proper place where he is calm, he's quiet, and the end of life care process could be started. Okay. So communicating with the family is extremely important. This might challenge you because, the acceptance levels of families are low. Anybody could be actually, low of acceptance. They may be in denial all the time. So you might need to continue with family discussions, team discussions. You might have to give a lot of time in counseling the patients and the patient family when you start weaning the introducing the end of life care measures for such a patient. So how palliative care at the end of life is different than regular palliative care provision. There would be definitely the primary aim is to relieve the patient of end of life symptoms. Mainly, the dominating ones are pain, dyspnea, and a lot of secretions. Okay. Reviewing existing care protocols, both medical and nursing. Reviewing the medication chart and stopping unnecessary medicines. Counseling regarding optimal hydration and food intake. Psychosocial support for the patient, for the family, caregivers, etc. Special emphasis to be laid on family meetings. And, these family meetings can be a request from the family itself. It may be a religious, spiritual, or even a cultural meeting. Taking this particular example of Mrs. RS, she is a 50-year-old lady with carcinoma of the stomach. She has come to the hospital in a terminal state. That's probably due to internal bleeding. BP is again 50. She's very, very restless. Now the question that triggers here is, will you give her parenteral midazolam, which may hasten deaths? Now the point which we need to understand here is that parenteral midazolam is the gold standard for treating terminal restlessness. Okay. And since we know that this is going to relieve her of the restlessness that she is going through, it might also hasten her deaths. Now, do you think it is right to give such kind of a medication to a terminally ill patient, which may inadvertently hasten the person's death? So that is an important question. And this is also, a situation that we often face when we are dealing with end-of-life care patients. And at this particular point of time, we need to remember the principle of double effect. And that says that a single act of having two possible foreseen effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. In this particular case, sorry, I can't go back to 1 minute. I think I have just crossed all. Rajlakshmi, can you give me 2 minutes? One is taking care of the restlessness, and other one is, hastening death. Now
Sorry to interrupt, but like the screen is blank for us.
Sorry. Is it
Yes.
okay now?
Yes, yes.
Yeah. So, for this particular patient, when we are using midazolam, we know that it has two effects. One would be, completely taking care of the restlessness, and at the same time, the patient might also die at that point of time. Okay, so our intention is to take care of the restlessness and not, uh, you know, uh, uh, provide her with death. Okay, so that is the reason why when we justify usage of such kind of medications, we will follow the principle of double effect. So there are many other examples. I think we are losing on time, that's why. But, there'll be many examples where you know that it has two effects. One is good, one is bad. You intend to give for example, if you give oral morphine, when we start oral morphine for our patients in pain, we know that morphine is going to cause harmful effects like constipation, nausea, vomiting, etc. But then the patient will get complete relief from pain. So our intention is to relieve the patient of pain and not to induce constipation. Okay. For constipation, we definitely use anti-constipating agents along with morphine. So, recognizing the dying process is an important step. How do we predict death? We are not fortune tellers, obviously, but then, there are trajectories in every end of life processes, in the trajectories that have been well defined for all kind of incurable diseases. For example, in cancer, there'd be a typical gradual deterioration, finally leading to death. So you know that the trajectory would be like this for a cancer patient who is terminally ill. Sudden death due to a catastrophic event like a massive hemorrhage, that's very rare in cancer. And the acute prognostication is quite difficult. So it is advisable to give time in terms of days, weeks, months, as evident from deterioration over time. So I really don't know whether you have been taken a session on prognostication or not. But then when we prognosticate, the we give the patient the time in terms of days, weeks, or month. If the patient is deteriorating over months, we prognosticate that the patient might actually live for a few months. Similarly with weeks and days. Sudden deterioration in patients will mostly indicate reversible causes like infection, hyperglycemia, changes in medications, etc. Okay, and this is very typical of cancer trajectory. If we talk about other diseases like old age dementia, Parkinsonism, renal dysfunction, etc. Those will have a kind of a dwindling kind of a trajectory. So these trajectories are also very important in recognizing the dying process. How do we diagnose? We all know, it is like the signs and symptoms of imminent death are cachexia, a gaunt face, weakness, bedbound, needs assistance for all activities, a decreased or nil intake of fluids and food, decreasing urine output, and so many other things that you can actually go through. You all know about this particular phase. The International Collaborative for Best Care of the Dying Person, they have actually, they maintain a chart for people who are at the end of life, and they have goals A to goal Q, and these are being done every 2 hours for patients. Okay, so you can understand how end of life care is followed in other countries or other places. So you can also do that in your setup, I mean, for your patients also. So last 48 hours, basically for palliative care patients, we see a lot of pain. We see patients in breathlessness, urinary dysfunction, nausea, vomiting, death rattles, and emergencies like stridor, convulsions, terminal restlessness, agitation, hemorrhage. And all these, I will not go into much details. I've just jotted them down. They have proper protocols to be followed, how to take care, what to give and what not to give, and what are the gold standard of taking care. And believe me, we can actually take care of every symptoms that I have mentioned here. A little bit about clinically assisted nutrition and hydration. I know it is a dicey kind of a point here, because many practitioners do actually give a lot of nutrition and hydration. For example, we give a lot of protein supplements through the and then a lot of hydration also. But usually, these are not beneficial at the end of life. And when I say at the end of life, there are no evidence. There is no scientific evidence behind this. At least you can't find any evidence in the literature. Thirst and dry mouth are usually due to mouth breathing or oxygen therapy. So it's important that you do a good mouth care. Frequent wetting of the mouth shall suffice to alleviate symptoms of thirst. And if clinically assisted artificial hydration or nutrition support is in place, the review rate or volume or route according to the individual need is very important. IV antibiotics should be rationalized and judiciously prescribed. If you find any evidence of infection, which is, which definitely might be there, you will definitely prescribe an IV antibiotic with the patient. So, managing intractable symptoms through palliative sedation is practiced in higher institutions where you have a specialized palliative care setup, and they are definitely possible at the end of life care, and they can be easily managed through palliative sedation. Not going into much details for palliative sedation, because it is a different chapter altogether. But the goal of treatment is relief of distressing symptoms at the end of life. So today's take-home message is that we apply ethical principles against a background of the respect for life and acceptance of the ultimate inevitability of death. If I would be in my deathbed, I would be, I would actually want to spend my time with my relatives all around and not surrounded by machines. So, so this is the end of my talk. Thank you so much. And if you have any other question, I am ready to answer them. Thank you so much.
Thank you, Sanghamitra. We will see if there are any questions. Participants, if you can unmute or you can type it in the chat. There is one question about palliative sedation, about what is the maximum period palliative sedation is advised. You are muted.
Yeah. So as I said, palliative sedation is a different subject altogether. But since you've asked this question, there shouldn't be any kind of a maximum period advised. It is a measure that you take, a decision that you take, in consensus with your with the patient's family. And we do palliative sedation for very, very intractable symptoms. For example, refractory breathlessness, refractory pain which is actually not, you have tried all the measures that are important. You have tried, IV morphine, you have tried methadone, you've tried multiple agents together along with interventional therapy, but still then the patient is suffering in pain. So then at that point of time, we decide on starting with palliative sedation. And that sedation doesn't mean that has to be continuous for all the time. You can actually, do a kind of a staggered sedation process also. It might be, you are sedating the patient for 6 hours and then allowing a gap of 1 hour or 2 hours, or till the time the patient again starts complaining of pain. Because when you stop the sedation, the pain actually comes back and the patient. So there is no, maximum time limit for palliative sedation. Having said this, there would be one thing that you will need to tell your patient family, that during the sedation, the patient might as well die, because we are not, playing with the longevity or the life that is remaining with the patient. We are actually trying to relieve the patient by sedating him with the best possible medications. And during that time, a natural process of death might also occur. So, as I said, it is the principle of double effect that applies to palliative sedation. So as such, not a period of sedation, not a maximum period. Yeah.
Yeah, I think Dr. Vijay has another question, I think, in continuation with the conversation.
Yeah.
Can it be a reason of being lucid or being with the family? It takes away the reason.
Okay. Well, cannot say that it takes away the reason of being lucid. It is just the fact that, the patient is sleeping. Patient sleeps and cannot appreciate, the central nervous system cannot appreciate the pain impulses that are centrally acting on him. Many a times when we, maximum of the time when we take care of intractable symptoms, these are, either a pain which is centrally sensitized into a complex kind of a pain syndrome. And at the same time, there may be other complicating mechanisms like extreme breathlessness. So, you are taking care of two complicated symptoms, two intractable symptoms at the same time. So I really don't think that, we are taking the reason of being lucid. We are just trying to give our best to relieve the patient of his symptoms that are so annoying for the patient as well as for the medical team and the family. So I don't know whether I'm able to make you understand what I, Dr. Vijay.
I just add to what Sanghamitra said, and
Yeah,
it
yeah.
is this will show the importance of having the proper communication well ahead
Yeah.
when the patient is conscious and able to make decision. We usually ask them, if your pain becomes uncontrollable or refractory at some point of time, we might have to sedate you. Will you prefer that? Some people say, even if I'm in pain, don't sedate me. I want to be, due to some religious reasons, very few people have asked us that I want to die without any sedation, no matter how much pain I'm undergoing. So we respect that. So it just actually shows the importance of having that advanced conversations with the patient and the family, that how the end. I think Sanghamitra's slide has had that, how do you want to die, or it's very like, we don't have to take the decision for them, like in the previous conversation that we had during the ethics. It is always important to ask, how do they want to be treated when the symptoms become refractory, and have the conversations with the family and document it. This is what the patient expressed his wish. I mean, that's a good practice. We may not be able to do it all the time, because sometimes the patient will be really agitated with terminal agitation. We may not be able to have a proper communication. But if you are anticipating things to be worsening in the future, if you are anticipating refractory symptoms, it is always good to have the conversation much ahead when he is able to tell what he wants.
Absolutely.
Absolutely. There is question on organ donation while on palliative care.
Okay, so I have not come across anything like that because, as I said, it is a wish of the patient that you will need to, because in one of those slides of good death, I did mention about, contributing, the patient's wishes for contributing. And that is very important. If the patient wants to contribute one of his organs, for example, the cornea, etc., that should be facilitated. And when it is regarding other organs, I think the specialist who deals with that will be the best person to judge that, best person to advise on that. And the thing that we can do is to facilitate the patient's wishes. We can actually call on somebody to, throw light on that particular wish of the patient, connect him to that particular authority who can actually, because there would be a lot of questions also, since the patient is going to die, or, the patient wants, is the wish is donating our organ. So those things could be actually facilitated by the palliative care team. So
Thank you. Dr. Priyadarsh has asked, how the patient will know what is going to happen with them. So asking them always, will it be the final word? I mean, just wanted to comment, Dr. Priyadarsh, it is very important to tell them what is going to happen, anticipate the symptoms. If the patient is prognosis is very bad, with the lung cancer, for example, we know that the breathlessness is going to be worsening. The pain is going to be worsening. They may have terminal agitation. They may have a lot of metabolic issues. So prepare them. And this may or may not happen, but make them understand what are the symptoms that can be anticipated in the coming days, preparing them as well as the family. It may be very difficult to start having that practice, but once you start having that, no, the decision makings are so easy, because you don't have to decide for them. They know what they want. They will tell you what they are looking for. So it is very important to communicate. That's how the patient should know what is going to happen with him, having an open conversation. Sorry, Sanghamitra, I just couldn't.
no, that's absolutely fine. Completely. Yeah.
And have a family meeting. Document whatever you have talked. Okay, had a meeting with patient Mr. A, his wife, and his brother. what all you have communicated, what all patient has told you. Just write it on a paper and keep it in your file. It's so easy for us to take decisions. Less ethical dilemma in that way. We can just facilitate them to take the decision. We can just be the facilitator. You don't have to be the decision maker at all.
Rightly said. Yes.
Cannot see more questions. So I think we can wind up today's session. Thank you so much for the questions. Very, very interesting, valuable questions for discussion. Thank you so much for the interesting questions and interaction. Thank you so much, Sanghamitra, for being with us for the last 1.5 hours and taking up all the questions.
Thank you.
Thank you so much, everyone. So over to you, Sri Priya, about tomorrow. Tomorrow onwards, the session plan changes. So
Thank you, Dr. Sanghamitra. It was really nice seeing you after some time.
Yeah,
And
thank
thank you so much for joining us. We do hope that your power has come back.
Yes, it does.
Okay. Just reminding that from tomorrow onwards, our entire structure is changing. I have already published the list of participants who are advancing to the next level in the group. So please do go through that, and please do take initiatives to form WhatsApp groups and start discussions and all. With the promise that we'll be meeting again tomorrow. This is Sri Priya along with Dr. Sanghamitra Bora and Dr. Sridevi signing off from the Tipsy Guha. See you tomorrow. Till then, everyone take care. Bye-bye.